Welcome, everybody. Thank you so much for joining us today. It's strange, perhaps even a little disturbing, that in 20 years of global health publications in the Lancet, which began, of course, with the initial series that we did on child survival, this is the first series that we have published that addresses the issues of reproductive, maternal, newborn, child, and adolescent health in conflict settings. Why? Why has it taken us so long? Partly, I think it's because the health and humanitarian communities live and work in very different disciplinary spaces where communication is not only suboptimal, but where miscommunication is not uncommon, for example, over standards of evidence or the interpretation of that evidence. But I also wonder whether the omission in coverage is because of two other possible forces. The first, perhaps, is that the existence of conflict is almost taken for granted now. As paper 1 points out, 9 out of 10 countries with the highest newborn mortality rates are countries in conflict. War has become an accepted part of the background to women's and children's health. It's become normalized in our thinking. And so with that normalization, it's too often ignored. A second force, a second problem is that somehow the issue of conflict is seen as beyond the scope of anything the health community can reasonably influence. We are not presidents or prime ministers. We are not peace negotiators. We are simply humble actors trying to provide services, care, and comfort amid complex and often intractable war settings. Now, this series, which is called Branch, Bridging Research and Action in Conflict Settings for the Health of Women and Children, addresses all three reasons for the relative neglect of this critically important field. The 4 papers do successfully bring multiple disciplines and communities of practice and research together, often for the first time, to create a reliable foundation of knowledge for action. The series challenges the normalization of warfare and its effects and issues a powerful moral claim on our attention. And the series proves that we are far, far from being impotent actors. There is much that the health and humanitarian communities can do together to deliver life-saving services and to enhance the security of that service delivery. So, to conclude, this series comes as part of the Lancet's effort to renew and revise the global attention being directed to reproductive, maternal, newborn, child, and adolescent health, which began last February, if you can remember back to last February, with the launch of our Commission on the Future Child. I'd like to thank the authors at the beginning, not the end, especially the Branch Consortium Steering Committee, Zulfi Buta, Bob Black, Carl Blanchett, Tis Burma, Michelle Gaffey, Anna Langer, Paul Spiegel, Ron Waldman, and Paul Wise, some of whom you will be hearing from in a few moments. I'd like to thank the principal funders of this work, IDRC, NORAD, the Bill and Melinda Gates Foundation, UNICEF, and PMNCH. And I'd like to thank my colleagues at the Lancet, led by Jocelyn Clark and supported by a great team, including Steph Clegg, Francis Painter, Sharon Crucifix, Sheila Pinion, Manit Verdi, and Lucy Shaitanova. Now, we have a little interlude where it's my great pleasure to welcome by video the Director General of the World Health Organization, our world's much needed global health agency, who will say a few words of introduction and welcome. So over to you, Dr. Tedros.
The COVID-19 pandemic has had a devastating impact in even the richest and most powerful countries. But in areas affected by conflict, the effects are even more acute, especially for women, children, and adolescents. We know that crises put children and adolescents at a much greater risk of impaired development. Young children are often deprived of opportunities to play, communicate, and learn. Adolescent girls in conflict zones are 90% more likely to be out of school. 1 in 5 people affected by conflict suffer from a mental disorder, almost 3 times higher than the global average. The pandemic is compounding all these vulnerabilities. The work of branch consortium, especially this Lancet series, shines a light on the gaps in quality care in conflict settings and shows why universal health coverage is not a pipe dream that can be put on hold until the pandemic subsides. UHC remains an urgent priority, but it hinges on political will to work across sectors and with local stakeholders to protect the health and well-being, needs and rights of women, children, and adolescents in conflict settings. WHO remains committed to working with our partners to safeguard those needs and rights and to build a more peaceful, equitable, and healthy world. Thank you.
Well, thank you very much, Dr. Tedros, and thank you, Richard, for that fantastic introduction. And I want to start by mentioning that it's been the great privilege of my life to have been part of this consortium and to have coordinated over the last few years with some of the best brains and minds this effort to try and shine some light on one of the greatest public health challenges of our times, the health and well-being of women and children in conflict settings. To some extent, my journey in this space was inevitable because one of the first exposures I had as a pediatrician after graduation was indeed looking at Afghan refugees, families, young girls and children in the aftermath of the invasion and the war in Afghanistan. So to some extent, this is payback time for some of that early experience and trying to do something about it at scale. We couldn't have done it without partnerships, and I want to start by thanking you, Richard, and the team at the Lancet. I can't believe that it was at the end of the MDGs when I tapped you on your elbow one day at the sides of the IRG meeting and said, you know, we need to do something about the health of women and children in conflict settings. And it took you a total of 10 seconds to say, yes, absolutely, we should. And it's been a journey. It's taken us 4.5 years to go from the initial inception workshop, where again, in a prescient, thoughtful manner, you sent Jocelyn Clark, who's been a wonderful partner, to join us in that workshop in Toronto, where we brought people together, and to almost a dozen meetings of the consortium in the intermediate 4 years to try and bring it all together, leading to the workshop in London in November 2019, where we brought some of the final versions of the thought process and the papers together to see what could be done. And little did we know at that time that within a month of that meeting, the world would be turned upside down with one of the greatest public health challenges that we've had. So this series also comes at a very opportune time because to a large extent where there is the least information on the impact of COVID-19 on the health and well-being of children is really in conflict settings where we have so little information because neither do we have surveillance systems, nor do we have data on its impact on outcomes. That's not to say it doesn't exist out there. So ladies and gentlemen, I know you're not here to listen to me, but to see what the meat of these publications are. And there are a number of people to thank in this process, but I want to particularly thank two people who helped us in the branch consortium. and me personally think through some of these issues from the very get-go. So I want to thank Bob Black for chairing our steering committee and keeping us in shape. And I know you will hear from him during the course of this morning. And I want to thank Ron Waldman. I want to thank Ron in particular because Ron and I worked through several crises in over the last 10, 15 years. And he has had absolutely the moral authority in terms of raising some of these issues directly with me and over the course of this experience. There will be an opportunity to thank others, but I would like to thank our steering committee, who were fantastic. And not only did they keep us on track in terms of what we needed to do, but also helped us think through some of the translation from the concepts to actually practical implications of these findings. And towards the end of our session, I'll be very briefly talking about what the next steps are. But without further ado, let me now move to the papers per se, that the 4 papers and the comment that form the meat of the publications. I'd like to start with Paul Wise, who led the first paper on the political and security dimensions of humanitarian response to violent conflict. And Paul is the Richard Berman Professor of Child Health and Society and the Professor of Public Health Policy at Stanford University. So Paul, the floor is yours to tell us what your first paper says.
Thanks very much, Sophie. First, I also want to say that it has been a privilege to have worked with my co-authors on this paper and to have been part of this branch initiative. I'm very appreciative also of your leadership and guidance, Sophie, and the expert support we've received from the Lancet editors throughout the development of these papers. This first paper attempts to bridge the fields of humanitarian health and human security. It attempts to provide in one place an overview of the political and security challenges that can transform laudable humanitarian intent into a complex and at times dangerous humanitarian reality on the ground. Can I have the first slide, please? This figure broadly outlines the humanitarian endeavor in war. The central humanitarian strategy of mitigation operates through 2 related mechanisms. The first is prevention, preventing non-combatants from violent attack in the first place. And second is response, responding with care and comfort to the needs of non-combatants when this protection fails. Health outcomes also take on 2 forms. The first are direct effects, physical and mental trauma due to the direct exposure to bombs and bullets. The second are the indirect effects, mortality due to the destruction of the essentials of life, including shelter, food and water supplies, electric grids, transportation networks, and health systems. Although these indirect effects almost always dwarf the direct effects, the targeting implications and causal pathways of indirect effects, and most importantly, the opportunities for mitigation remain in urgent need of further empirical analysis. Next slide. The most fundamental message of this paper is that the political and security challenges confronting humanitarian action are intensely dynamic. The nature of warfare, as well as the nature of combatants and their portfolios of violence, can vary and evolve quickly in response to changing security and political considerations on the ground. Of special concern are the use of explosive weapons in densely populated urban environments and proxy and hybrid strategies that link the operations of local fighters and militias to regional or global powers with deep resource pockets and highly sophisticated intelligence and cyber capabilities. There has also been a proliferation of armed non-state combatant groups, many of which blend political goals with criminal activities, an interplay that can be difficult for humanitarian actors to discern, which in many instances can enhance their vulnerability to attack. In this context, it is important to recognize that in areas of violent conflict, local communities, while experiencing great suffering and pervasive risk, are almost never passive. Local humanitarian responses are often the first and most trusted forms of community-based protection and can help ensure the effectiveness of international assistance. Can I have the next slide? Thanks. These complex and dynamic security environments can also exacerbate the impact of infectious outbreaks, such as COVID-19. Experience from the Ebola outbreaks in West Africa and the Eastern DRC, and more recently from COVID-19 in unstable areas, the provision of health services can quickly become mere currency in the struggle for power. In some areas, armed non-state combatant and criminal groups have taken charge of distributing COVID information and supplies in a strategic effort to enhance their legitimacy and ultimately their power at the expense of the state. Humanitarian protections and norms have also always depended on a collective global order and support of powerful states. However, recent political developments in the US and Western Europe and the enhanced global posture of China and Russia have the potential to destabilize longstanding commitments to international humanitarian norms, institutions, and cooperation. In sum, effective humanitarian provision will need to adapt and adapt quickly to the contours of the political and security dimensions of armed conflict in diverse settings around the world. For it will be the effective negotiation of these dimensions that in the end will best ensure that the humanitarian actors will be able to provide some measure of protection and comfort to communities enduring the depredations and horrors of war. Thank you, Sophie.
Well, thank you very much, Paul, for giving us this snapshot into the changing landscape and dynamics of conflict. What we need to go from there is to see what impact and what magnitude of impact do we see on the lives, health, well-being, indeed on survival of women and children in conflict settings. And we couldn't have gone to a better person to explore this than Professor Iran Ben David. Iran is an infectious disease physician and associate professor in medicine in the Division of Primary Care and Population Health at Stanford. He's also a senior fellow at the Woods Institute for Environment. And Iran published two very important papers in Lancet Global Health on looking at the impact of conflict on child survival in Africa, and then at a joint work on looking at maternal health outcomes. And in this particular paper in the series, he explores the effects of armed conflict on the health of women and children in partnership with Thies Borma and others. So Iran, the floor is yours, please.
Thank you. And I'd also like to thank Zulfi for his tireless leadership on behalf of women and children worldwide over a long period of time. I would also like to thank Thies Borma, who has led this paper with me, was my partner in this, and the rest of our authors, really for very thoughtful contributions and perseverance over several years. And so this is the culmination of a lot of work. This portion of the series surveys the burden of armed conflict on the health of women and children. And we conceptualize armed conflict as akin to a disease or risk factor, a condition whose mitigation is possible and whose reduction would improve health and well-being. Can we have the first slide? The backdrop for our work shown in this figure is the persistent pattern of armed conflict in the world. Despite large declines in armed conflict in some parts of the world, such as Europe since World War II, the past 30 years have seen persistent levels of armed conflict. Somewhere between 42 and 68 countries have seen armed conflict within their borders between 1989 and 2018, with armed conflict events heavily concentrated in the Middle East, Central Asia, South Asia, and Africa. The persistence of armed conflict has remained elevated. And the nature of armed conflict is evolving, as we've heard from Paul, but there's no reason to think that this is going to become a diminishing problem, especially over the past year with all the challenges that are emerging. Can we have the next slide? So against this backdrop, the number of women and children affected by armed conflict has grown steadily, at least since 2000, probably before, since 2000 is when we started measuring. This is due to a combination of increasing population sizes, the urbanization of many conflicts affecting large cities and dense populations, the persistence of armed conflict. In 2017, at least 630 million women and children, 10% of all women worldwide and 16% of all children worldwide, were either displaced by conflict or resided close enough to conflict, to armed conflict events, that their health was endangered. Next slide. Women and children's mortality risk from nonviolent consequences of armed conflict, what Paul called their indirect effects, increases in response to nearby conflicts, with more intense and more chronic conflicts leading to more deaths. More than 10 million deaths among children under the age of 5 years globally can be attributed to conflict between 1995 and 2015. How does conflict harm the lives of women and children? We document many ways in which health is affected by conflict, but systematic evidence is sparse. Existing evidence provides linkages between conflict and malnutrition, physical injuries, infectious diseases, poor mental health, and poor sexual and reproductive health. However, the evidence is typically localized and of moderate quality. Data on adolescents is really sparse to non-existent, yet this population is very important as well. Future work and methods to characterize the health harms of armed conflict on women and children is an important part of prioritizing and targeting interventions, which we will hear more in this series. So with that, I will turn it back to Zulfi and to hear more about some of these issues.
Thank you very much, Iran. And one natural question from all of this is really, if those are the global numbers and the global thinking, what is the situation on the ground? And we are very grateful to Carl Blanchet and Neha Singh from the London School of Hygiene and Tropical Medicine, and Carl's now at the Geneva Center for Humanitarian Studies, for having led the work on looking at some of the highest burden conflict countries in depth on the situation, and also how the response was configured in those particular circumstances. So Neha, who is the co-director of Health and Humanitarian Crisis Center and is a professor at the London School of Hygiene and Tropical Medicine, will present this paper on behalf of the team on focusing on delivering health interventions for women, children, and adolescents in conflict settings. What have we learned from the 10 country case studies? And to mention that these individual case studies have all been published in DMC Conflict and Health, and you would have received the link to those, where those individual countries have been evaluated in depth. So Neha, over to you.
Thank you, Zulfi. Hi, everyone. So today I'm going to briefly discuss our study, which, as Zulfi said, presents insights from a collection of 10 country case studies, aiming to assess the provision of sexual, reproductive, maternal, newborn, child, and adolescent health and nutrition interventions, or what we have shortened to say WCH interventions, women and children's health, in contemporary conflicts in Afghanistan, Colombia, Democratic Republic of Congo, Mali, Nigeria, Pakistan, Somalia, South Sudan, Syria, and Yemen. Next slide, please. So today you only see me presenting, but I would like to acknowledge Professor Carl Blanchet, with whom I work very closely on this paper. And I would also ask that you please note every single person's name acknowledged in paper 3 of the series, as this work was collectively done by 82 researchers from 24 institutions in 14 countries, the vast majority from the 10 case study countries. I'm immensely humbled and grateful for the opportunity to work with and learn from everyone in the case study country teams. So thank you. Next slide, please. So how did we do this work? We used both qualitative and quantitative methods and applied a framework analysis approach to describe the coverage and spectrum of WCH interventions delivered. We also looked at the explanatory variables affecting variation in health service delivery, specifically by analyzing decision-making processes, obstacles to implementation of proven interventions, and adaptations of service delivery strategies to address the health needs of women, newborn, children, and adolescents in very varied geographic, political, economic, and environmental conditions. Next slide, please. So in this slide and the next one, I'm going to give you a very brief preview of our results. We know that international and local humanitarian actors and local and national authorities are confronted by various obstacles to deliver WCH interventions. So for the purposes of the study, we developed health and humanitarian system building blocks, which is an adaptation of the WHO health system building blocks, and classified our findings according to the domains you see in the column on the left. I won't go into details here, but please do refer to the first figure in the paper for a summary of these bottlenecks. Next slide, please. To follow on, we also investigated, there we are, thank you. We investigated creative solutions that humanitarian actors have used to implement services for women, children, adolescents in conflict settings. Table 3 in our paper summarizes these solutions, which include but are not limited to remote management, the emergence of pooled funds, localizing healthcare delivery, and rebuilding trust with communities. Next slide, please. So in terms of key messages, we found that despite very large variations in context and decision-making processes, antenatal care, basic emergency obstetric and newborn care, or BMONC, immunization, treatment of common childhood illnesses, infant and young child feeding, and malnutrition treatment and screening were prioritized in the 10 conflict settings. That being said, many life-saving services, including the majority of sexual, reproductive, newborn, and adolescent health services, were reported as not being delivered in the 10 conflict settings. Moreover, interventions to address stillbirths are completely absent. International donors remain the primary drivers of influencing the what, the where, and how of implementing interventions. And priority predefined packages of WCH services are not commonly agreed on and implemented in these settings. So an effective strategy to deliver care to women, children, and adolescents should include proactively defining and agreeing upon an evidence-based comprehensive package of interventions, taking into account existing evidence and guidelines, such as the Newborn Health and Humanitarian Settings Field Guide, the Interagency Field Manual on Reproductive Health and Crises. My colleague, Michelle Gaffey, will be talking more about this in the next presentation. Next slide, please. Furthermore, we found that working within the political and governance systems in modern conflict settings is increasingly challenging given the dynamic nature of modern conflict and the expanding role of non-state armed groups who are often in control of large geographic areas. And this poses new challenge to delivering services to women, children, and adolescents, as Paul Wise just spoke about. That being said, the humanitarian system is creative and pluralistic and has developed some novel solutions to delivering these life-saving services and bringing them closer to populations, as I mentioned earlier. These solutions, when rigorously evaluated, can represent a concrete, timely response to current implementation challenges and remind health authorities of their responsibility to deliver basic health services to these target populations. It's also critical that we recognize and value the role of local actors to improve timely and appropriate care of WCH services. The humanitarian system must go beyond lip service and allocate enough financial, human, and other relevant resources to local actors, while also ensuring that risks involved in delivering care at the front lines are not transferred to local actors. Finally, last but certainly not least, while the needs of conflict-affected communities are great, their voices are also often unheard or overlooked. It's therefore crucial that they have a seat at the table and that humanitarian actors listen to them when decisions concerning them are being made. I'd like to end by saying that while it's clearly imperative that the world make more efforts to reduce the risk of conflict, until that happens, improving the delivery of health and nutrition services for women, children, and adolescents in conflict settings remains an ethical and moral responsibility. Thank you.
Well, thank you very much, Neha, and for setting the scene. And clearly, you have led us to the fascinating thought process that we could do something better than what we are doing right now, particularly from the knowledge of what's been happening on the ground in these countries. And it gives me the greatest pleasure to introduce my colleague, Michelle Gaffey, who is a senior research manager at the Center for Global Child Health here in Toronto, and also an associate editor at BMC Conflict and Health, who's been both my right and left hand over the last 4 or 5 years as we built this series. And Michelle oversaw the publication of a large number of systematic reviews that actually explored what was the current knowledge of interventions in relation to women and children's health in various settings, exploring a whole range of things that I would encourage you to read, from mental health to non-communicable diseases, infectious diseases, immunization strategies, so on and so forth. And in this particular paper, Michelle and team put together how we can deliver these health and nutrition interventions in different conflict settings, and speak about a framework for decision making on the what, how, and when, along with her a fantastic team. So, Michelle, the floor is yours.
Thank you, Zulfi. Thank you. Okay, I'd like to start by acknowledging my co-authors on this paper, including colleagues formerly at WHO, as well as colleagues from Save the Children, the International Federation of Red Cross and Red Crescent Societies, the International Rescue Committee, MSF, and the Emergency Nutrition Network. So this paper evolved from two other branch work streams. One, as Zulfi just mentioned, was a set of systematic reviews of the literature on intervention delivery for women and children in conflict settings. And secondly, a systematic assessment of the existing global guidance relevant for women and children in conflict settings. So the findings of both work streams, which are now published elsewhere, underscored the very limited availability of evidence and guidance specific to conflict contexts. And so that led us to think about what could be done now in the short term to help fill, or at least to bridge, that guidance gap. So what I'll briefly outline here is the decision-making framework that we developed, and also how we piloted this framework by applying it to a set of hypothetical conflict contexts. Next slide, please. So step one of our proposed decision-making framework focuses, not surprisingly, on the assessment of needs among women and children in a given conflict setting. So to determine which health and nutritional conditions should be targeted for intervention. Step two is then to identify those interventions that, if they were implemented, would address the assessed needs. And these interventions should then be considered potential priorities for delivery. Step three is then to assess whether and how each of those interventions identified as potential priorities in step two could actually be delivered in the given setting, considering prevailing levels of insecurity and the human and material resources available, as well as any other local factors that could affect intervention delivery. Next slide, please. We piloted our proposed decision-making framework by applying it to a set of hypothetical conflict contexts. And to define those contexts, we used this conceptual framework I'm showing here, which the branch consortium developed early on to help guide its thinking about intervention delivery in conflict settings. So this framework broadly classifies conflict-affected areas and populations in terms of their exposure to active violent conflict, and by extension, their access to health services. So populations located in conflict epicenters, as we've called them, are presently experiencing acute active violence, and so population mobility, and therefore access to and by health workers, is severely restricted, if even possible. Insecure areas are those where the threat of attack might be imminent, but the population is not presently exposed to active violence, and so population mobility and access to health services may actually be unrestricted, if only temporarily, through the negotiation of humanitarian space. And then stable areas are those in which displaced populations have settled in relative safety, either in camps or dispersed within host communities, and generally have ongoing access to health services. Next slide, please. So by applying our proposed decision-making framework to each of our three hypothetical conflict contexts, we identified illustrative, not prescriptive, but illustrated packages of priority interventions for each context. For step one, we necessarily used a simplifying assumption of a high burden of a wide range of health and nutritional conditions among women and children being high in each of these three contexts. In step two, we then compiled a set of 77 evidence-based interventions that would address the conditions we assumed in step one, drawing from those interventions that are already recommended in key sources of humanitarian guidance, some of which Neha just mentioned and which we detail further in the paper, plus a small number of additional interventions drawn from non-humanitarian guidance. And then for step three, we convened in person to discuss whether and how each of the 77 candidate interventions could actually be delivered in each of our hypothetical conflict contexts. And so we considered the lowest level of care at which each intervention could be appropriately delivered, whether that's in the community or in primary healthcare facilities or in hospital. And then we assessed whether that level of care was likely to be available in each context, especially given their varying levels of insecurity. So we detail the results in the paper in quite a long table, but in summary, we ended up prioritizing only 17 urgent life-saving interventions for conflict epicenters, where violence is acute and the personal safety of care providers and care seekers will often outweigh the imperative to provide comprehensive services. We prioritized 74 of the 77 interventions in insecure areas where a much wider range of interventions may be implemented, if only temporarily. And then we considered all 77 interventions to be priorities in stable or secure areas, as it's labeled here. Next slide, please. And so some key messages from this paper are that evidence-based guidance on women and children's health and nutrition in conflict settings specifically is limited, but urgently needed. And as a preliminary step toward filling that guidance gap, a framework for decision-making that explicitly takes conflict context into account could improve response effectiveness and perhaps also accountability for the decisions that are made. Then ultimately, in a given conflict setting, effective interventions that address local needs and that can feasibly be delivered should be prioritized. Thank you.
Well, thank you very much, Michelle, and we'll be talking a little bit more about the implications of these. But the final linked comment in our series talks about the way forward and some recommendations from the consortium in terms of building on what the scholarship is already in these 4 papers. And it gives me great pleasure to introduce Paul Spiegel. Professor Paul Spiegel was, until fairly recently, the Deputy Director and the Chief of Health at UNHCR, and he now leads the Hopkins Center for Humanitarian Health at Johns Hopkins University as its director. And Paul, can you kindly take us through some of the thinking around what may be a way forward?
Sure, thank you. Firstly, thank you to the Lancet for helping to publish the series, and of course to Zulfi for leading us through this. So in 2017, after nearly 15 years of working at the UN Refugee Agency, I wrote a paper in another Lancet series on health and humanitarian crises, reflecting about some of the lessons that I learned, and the paper was called "The Humanitarian System is Not Just Broke, but Broken." And I called at that time for a prioritization of protection, to integrate affected and displaced people into national health systems, to scale up more effective and efficient and sustainable interventions in humanitarian settings, and to renew global leadership and coordination. So now here we are in a COVID pandemic in 2021, and we have this new, very important series on women and children's health in conflict settings. Some of the same issues that we'd called on previously, unfortunately, are still very, very relevant today. So given the large-scale outbreaks of Ebola in West Africa, the massive cholera epidemic in Yemen, and now the COVID-19 pandemic, perhaps it's not surprising that the humanitarian system has been distracted as the world has moved towards addressing epidemics of global health security. However, many of these epidemics, and we've heard this today, repeatedly occur in fragile and conflict settings, and they disproportionately affect women and children. But of course, it's not just the epidemics. As both Paul Wise and Aaron just talked about, the indirect effects are enormous. Reducing access to care, increased sexual violence, reductions in childhood immunizations, and increasing maternal mortality are just among many of the negative consequences that occur. However, available guidance on promoting women and children and adolescents' health and nutrition are still not specific enough for these diverse contexts of conflict. We still lack sufficient evidence for particular interventions, and as Iran said, adolescence is practically non-existent. And there's a need to undertake implementation science, which really means the scientific study of methods and strategies that facilitate the uptake of evidence-based practice and research into regular use. And given the insecurity and need for culturally appropriate interventions, such efforts are likely to require task sharing and reliance on community health workers. We've been discussing localization and the imperative to meaningfully engage communities in humanitarian planning for decades. However, a recent evaluation of the Grand Bargain by ODI, which is an agreement among some of the largest donors and humanitarian organizations who have committed to get more means to people and to improve the effectiveness of humanitarian action, is still far behind what has been agreed. The humanitarian health sector is complex, with multiple actors operating within and across jurisdictions and covering much more than just a health response. The responsibility for coordination and oversight of the humanitarian health response in countries lies with governments. But as Paul Wise emphasized in his paper and his presentation today, when governments are a party to conflict, humanitarian principles are unable to be maintained, and then regional or international leadership and response generally is required. However, there are many evolving and complex international coordination systems for large-scale epidemics and humanitarian responses that don't speak to one another and still do not sufficiently engage local NGOs and civil society partners on the ground, never mind the affected communities. Most humanitarian funding is still going to international NGOs in the UN system and it's bypassing governments and local NGOs. So a hard look as to how the humanitarian coordination and funding for humanitarian emergencies occurs must be undertaken, particularly in the age of the COVID pandemic, where governments and national NGOs were not able to count on the humanitarian machine in the same way as they were in other crises. So we're proposing that agencies leading global humanitarian responses, NGOs, academics, and representatives from affected communities convene an independent technical advisory group. We're suggesting that there is a need to establish a decision-making framework, a bit what Michelle was just discussing in terms of prioritization, for the selection of interventions for women and children in conflict settings. We need to promote the strengthening of data collection and analysis efforts, and we clearly see some of the major problems in being unable to get sufficient data in this COVID crisis amongst these groups, and to help develop a standard set of indicators according to different contexts. The same group could also assist in developing implementation research priorities to help fill other gaps in operational and implementation guidance. While some of these recommendations may not seem new to you at this point, we believe that the time is now right to actually implement them. As the world struggles to overcome the challenges of the COVID-19 pandemic, and more open discussion about the decolonialization of humanitarian development assistance is occurring, perhaps finally the global health community will have the resolve to support the capacities of populations affected by conflict and displacement, and ultimately to improve the health and nutrition of women and children in these settings. Thank you.
My name is Espoir Bwenge Malimbaka. I am a medical doctor trained in epidemiology and biostatistics. I grew up here in Bukavu, in Eastern Democratic Republic of Congo. I spent a few weeks of my childhood in a settlement for internally displaced persons in 1998 when my family was fleeing the war that erupted in Eastern Democratic Republic of Congo. I was part of the DRCK study. Our objective was to examine how reproductive, maternal, newborn, child, adolescent health and nutrition services have been offered in the Kivu since 2000 and how successful they were. One of the key insights we gained from this study is that as insecurity in the Kivu has become more and more driven by local armed groups rather than by external actors, the consequence on health is now less predictable. Some local actors, for instance, may allow health actors to operate as a way to legitimate their power in front of the communities. Some might even understand the importance of, for instance, vaccinating the children in their community. On the other side, the population has also adapted to insecurity, for instance, by seeking health services in neighboring health zones or by moving to health facilities when they see an NGO's car approaching, for instance. We also found in this study that the coverage for essential reproductive, maternal, newborn and childhood interventions was high in the Kivu, often higher than the national level. And surprisingly, the health outcomes were poorer in conflict settings compared to stable ones. These findings mean that while maintaining and sustaining key reproductive, maternal and childhood interventions is critical and very important, it does not suffice as exposure to other environmental hazards like poor water and sanitation, poor quality of health services may also have a huge impact on health. Thank you.
The last 70 years in Colombia have been marked by an internal armed conflict that extends across the country. It involves different legal and illegal groups and has distinctive urban and rural characteristics. Despite the conflict, health services were provided without interruption in some areas, especially in big towns and cities. However, these increase the disparities in health status between rural and urban areas, as rural areas typically have a higher presence of armed actors. We calculated 16 indicators between 1998 and 2016 using official secondary data sources. In those 18 years, all of the indicators show improvement. However, 4 of them reveal statistically significant differences between municipalities with high levels of conflict versus low ones. Maternal mortality ratio and adolescent fertility rate were higher in the municipalities with higher conflict. The percentage of C-sections and prenatal care were lower among women who experience highest levels of conflict. In conflict areas, there was limited availability of health interventions, lack of human resources and supplies, geographical access difficulties, and insecurity. The national government was the principal provider of services, with difficulties in continuity and quality. UN agencies and NGOs accessed more easily remote and intense armed conflict areas. Few specific health interventions were identified in the post-agreement context with the guerrilla of FARC.
Well, welcome back, everybody, and I hope that you're paying attention very closely to what you've heard, because now's the opportunity for you to engage in a panel discussion. And it's my great privilege to introduce 4 real experts in this area. Let me introduce them to you. Liz Mason, who has, of course, many of you will know from her fantastic work when she was at WHO, directing women's and children's health programs, but now representing the Independent Accountability Panel. Esperanza Martinez, who's representing the International Committee for the Red Cross. Wais Karani, the Afghanistan Nurses and Midwives Council, and Paul Fife, the Norwegian Agency for Development Cooperation, NORAD, who's been such a fantastic supporter of this work. Now, friends, what I'd like you to do first of all is to offer some reflections on what you've heard, on any aspect of what you've heard. And Liz, I'm going to start off with you first.
Thank you very much, Richard. And really, it is a very impressive series. Earlier, when Zulfi was setting up the series, the Independent Accountability Panel was looking at conflict settings and accountability. And Zulfi said, well, we are preparing a series on, the Branch Consortium is preparing a series, and maybe you want to look at what we come out with. Well, I think that in terms of what they've come out with, showing the data that's there, and importantly, the data that's not there, highlighting the fact that if we don't address conflict settings, then globally, we're not going to reach the SDGs. Putting forward a framework for action. And I'll speak more about the framework for action and how this can really highlight accountability later. But importantly, that the UN agencies, the international organizations that are working in conflict settings actually don't necessarily work together and don't necessarily work in harmony. And that idea that they need to work in harmony, I think, can really take us forward in the future. If this is the single most important issue that comes out of this, harmonization of the work, so that all of those interventions can be implemented and not just the few that are selected by one agency or another.
Thanks very much, Liz. Esperanza, let's turn to you from ICRC.
Thank you very much. I think this is an issue very close to our heart and our mandate and our work. And I would say that there are two key elements of importance in the series. And the first one is really raises awareness on the double burden faced by children, adolescents, and women in armed conflict settings. On one hand, you have the issue of really weakened and dysfunctional health systems, particularly in protracted crises. And there are so many of those today in the world. But on the other hand, it's really the burden of long-term neglect. We see that women and health indicators, particularly in health, are very low in many armed conflict settings. And the series confirms that. So the awareness element is quite important. I would say the second one is that the series emphasizes the need to do better. And I will argue that we also need to do more. The ICRC has calculated that there are more than 100 armed conflicts in the world today, and more than 60 million people live in these areas. So that's a lot of women and children. So we do need to do better, and we need to do more. And the series really helps to bring these elements together. And most importantly, the series presents an overview of the present and really identifies what we can do to change that towards the future. So I think that that's quite a significant step forward. Thank you.
Thanks very much, Esperanza. Wais Karani, the Afghanistan Nurses and Midwives Council, please.
Thank you, Horton, and hello, everyone. I think the findings were very much important. First of all, we can conclude that the figures and the statistics which are shared in these articles are alarming, and it gives a clear message for all sides of the conflict that the effect is catastrophic. Secondly, the findings also inform the policymakers and even individuals to take the agenda forward and design targeted interventions on the evidences highlighted in this series. Furthermore, we can also see that how donors and governments may show flexibility in allocating adequate resources on prioritized and the most important and critical areas in the affected countries. And I also believe and hope that all will feel accountable on their part to play their role in overcoming these challenges faced by the respective societies in order to have a better future for women and for the children. Thank you.
Thanks very much, Wais. And finally, Paul, your reflections from NORAD.
Thank you, Richard. First of all, I agree. I mean, it's a great series of papers, very needed, very timely. First, it's clear there are global guidance documents, but it does highlight some gaps which are concerning in the areas of sexual and reproductive health and rights, and also in newborn and adolescent health. The second thing, which is important, it puts the interventions themselves within a broader operational and systems perspective, which is really important, highlights the importance of the workforce, of the need for good data, using the data, of course, and also community engagement. So that's really important. But really the highlight of the series is putting, shall we say, the more intervention, shall we say, the science and the operational aspects around this in a broader political and security context. That is not easy, but that's really, shall we say, where we should be going in areas of conflict. So it's a great series and looking forward basically to be here and congratulating everyone.
Thanks very much, Paul. We might come back to some of those further points as we carry on our discussion. Let me come now to a few specifics in your own particular areas of expertise. So, Liz, let me circle back to you, and I want us to talk a little bit about accountability. Now, you and I have been treading the path of accountability for perhaps about a decade now. With varying degrees of success. It's a complex landscape, even without the humanitarian dimension. The various bodies, including the Human Rights Council and so on, navigating these is never easy. How can we strengthen accountability in this reframing of women's and children's health, bringing in the humanitarian dimension? It's clearly tough. What steps could we take?
Thank you, Richard. I'd like to bring us to the framework for accountability that the IAP built on what the Independent Expert Review Group did. And in our framework, there is monitor, review, remedy, and act. And this has been expanded in the last report with 4 key areas of commit, justify, implement, and progress. And just to say how this relates to the series, if we talk about monitor, pulling that data together has been done so expertly by this group. It shows that data can be made available, but there is an imperative also to fill those data gaps, and pointing out those data gaps, which the series has well done, can help to move forward, particularly looking at, for example, the lack of data on adolescents. Then what does the data mean in our reviewing process? The detailed analysis that's been undertaken by the consortium, importantly on both the direct and the indirect effects of conflict. And we're seeing that with the COVID pandemic, that many of the indirect effects may end up in the long term being equally bad as the direct effects of COVID. So I think that we often don't really analyze well enough to look at those indirect effects. What needs to be changed? And I think that the team has very well put forward issues such as the harmonization of the guidelines, understanding the local situation, and I think very importantly, this involvement of local communities and helping to empower the local communities to make them more resilient. Already they are taking action. They're not just receivers. They can be movers and shakers themselves, and using the local community for delivery of services, but also to hold those that are giving the services accountable. And acting, this framework that has been put together is certainly a way of acting to move forward, and can really include an accountability focus. Because if you implement all of those steps of the framework, then together that actually is putting a focus on accountability for all that are involved in humanitarian action, and both the donor organizations as well as the international organizations that are implementing, and the local communities. So that's where I would like to place it in the framework of accountability.
Thanks, Liz. And I mean, there's an opportunity to coordinate work with other groups, I guess. I think we've got 1,000 people watching us today, and one person's written in asking a question, and particularly to you, about the potential for collaboration with, for example, the Interagency Working Group on Reproductive Health in Crises. Perhaps there's a way of connecting some of these different bodies so that we could strengthen accountability, so that the sum is greater than the individual parts.
Absolutely. I think that in terms of the comment of the series, and saying, having a body that coordinates, there does need to be much more harmonization and much more coordination, and having representatives from the different groups can help to move that area of accountability in terms of harmonization forward.
That's very good, thank you. Esperanza, let me turn to you now. Now, one of the key messages, and it was highlighted in the presentations, is that adolescent health really has been neglected very much in this whole arena. Adolescent health came late to the whole discussion about reproductive, maternal, newborn child health, and even later in thinking about conflict settings. I wondered if you could from your experience, talk to us a little bit about the needs of young people and what can be done.
Thank you. I think I would like to highlight two different points, and I will start with one that Paul referred to, Paul Spiegel, and is that in many countries where the International Committee of the Red Cross, and many of you actually work, adolescence doesn't seem to exist. Human beings are classified as children or adults, and when they are adults, they marry. But this adolescent period doesn't seem to exist. And we see this ambiguity, for example, where in many contexts, we don't speak about, it's very difficult to speak about child marriage, because it's preferable to say early marriage, because we cannot recombine this idea that we have a person, a human being, which is a child, performing an adult-related role. So we see this in practical levels in where we work. So what do we do with that? The first issue is really to work humanitarian workers at community level and administrative level to make sure that adolescence is not only recognized as a biologically specific period, but also as a period which is fundamental for the social and the physical development of human beings. And it also has a specific health needs. So it's really raising awareness. I come back to my awareness raising point, which needs to be done also in the humanitarian context. In many of the contexts where we work, you are aware that we have a lot of children and adolescents enrolled as fighters. So they are weapon bearers. So they are deprived furthermore of this evolutive period of adolescence, not only from a reproductive and health point of view, but also from a social perspective. And the second one is that we encountered very often this misconception that young people are not sexually active. And therefore, many of the sexual and reproductive health services that are in offer are catering for married women, for married men, or for couples. And therefore, this segment of adolescents are kind of left in the limbo, and we also need to recognize that. And moving forward, we actually see in the last decade, in many of the countries where we work, more awareness and more importance given to the issue. So ministries of health in many countries have incorporated policy and planning on adolescent health. But then we fall into this issue that was also raised. There are so many other competing priorities, and resources are not enough, that unless resources are specifically catered for adolescent health, they are going to be spent on something else. And the catering for adolescent health can really be anchored at community level, can be really anchored in civil society, in adolescent groups and young people. We have, particularly in Africa and in contexts with a very big volume of young people, youth groups that they themselves can really rally and can be part of the solution. But this needs resources, and particularly earmarked resources to move forward.
Thanks, Esperanza. Let me just ask a follow-up now, because we're getting a whole host of questions coming in from our audience. And it actually relates to a point that Liz and I were picking up just a moment ago, and that is about, again, harmonization within the NGO community. How can we promote better coordination across the many groups who might be involved? Any reflections?
Yes, I think the exercise and part of the series and was presented today is really to identify what do we need to do where. So we need to acknowledge that armed conflict is a very big concept. And we do have active conflict, we have insecurity, we have all these layers that were presented before. And that they are very in-depth. There is an in-depth analysis in the series. So by recognizing that there are areas where communities and people cannot access healthcare, but there are basic things that we need to do, we are already agreeing to a standard set of norms and interventions that we need to apply. We have done a similar amount of work in the field of NCDs, for example, by agreeing within the humanitarian sector what are the minimum conditions that need to be treated in every humanitarian context. So by agreeing among the different humanitarian actors and ministries of health and governments that those elements are a must, disregarding of the level of insecurity that is being faced, I think we already have one step forward. I think one of the challenges we have is that very often we aim for perfect. And actually we need to aim for good enough, where populations cannot move, where access is severely restricted. But there are minimal life-saving conditions that we need to tackle. And allow me, Richard, here, for example, in Yemen today, we see there is a lack of access to reproductive and health services, including HIV prophylaxis, sexually transmitted diseases, safe management of abortion, and so on. So there are basic life-saving interventions that today are not delivered. They should be present.
Thank you, Esperanza. Very powerful messages we need to take away. Let me turn now to Wais Karani from the Afghanistan Nurses and Midwives Council. Now, Wais, I want you to speak as a frontline worker and to tell us a little bit about your direct experience regarding the health. When we say women and children, we're looking at the broad context: reproductive, maternal, newborn, child, and adolescent health. The health of women and children in settings of armed conflict. Please share with us some of your experiences, particularly regarding what we can do. This is a series about action. So we're not impotent actors, we actually can do things. So tell us a little bit from your experience about what we can do.
Thank you. We know that, consistent conflicts over 4 decades have severely affected Afghanistan's infrastructures in all aspects, unfortunately, including health systems and healthcare. Women's and children's health indicators have badly affected and unfortunately remain among the worst globally. And there are numerous contributing factors or barriers. Some of these are applicable to both hospital level and also in rural facilities. And some others are unique to the rural settings. I'm going to focus on very few areas. Despite having admirable improvements and developments over the last few years, access to a sustainable healthcare services has still remained a challenge in Afghanistan. The geography of Afghanistan, cultural norms, insecurity, and many other factors have further worsened the condition. Where hospitals and facilities exist, quality is a big concern. Emergency and complex services are either not available, or if they are available, it is not within the reach for in the remote area for all population. Resources within the existing facilities are very limited in terms of medicine supplies and also in terms of human resources, mainly female nurses and midwives. Before I touch on the other areas, I would like to quote from Dr. Tedros, and he says that, my discussion will focus how we can go forward. He says that we will have best medicine, best diagnostic centers, best hospitals, and best health insurance. But if there is no healthcare providers, especially nurses, to deliver intensive, effective, and safe services to public, we don't have health system. And he adds, we simply cannot achieve universal health coverage and health-related targets and SDGs unless we empower and equip nurses and midwives and harness their power. Being a nurse, I strongly believe on this. And those who are working for women and children's health are nurses, midwives, obstetricians, and gynecologists who are largely women in our context. For them, we should invest on the provision of safe workplace environment and capacity development initiatives. Bringing 36-hour shift duties, we know that there are nurses and midwives who are working continuously for 36 hours in one shift. And to a reasonable working hours and standardized nurse-patient ratio, reward and recognition, workplace safety policy, job security, and reasonable compensations are some of the important areas to improve workplace environment, which ultimately empower women who would definitely work for women and children's health. In Afghanistan, due to unavailability of educational opportunities in nursing and midwifery, unfortunately, most of our nurses and midwives are engaged pursuing higher education in other disciplines, mainly medical. Considering the women's and children's health and to minimize nurses and midwives attrition, they could be further trained on highly demanded specialties which is highlighted in this series, like public health and clinical nutrition, neonatal nurses, intensive care nurses, and so on. So these are the main areas that we should focus on the capacity development of nurses and midwives in order to have a better and quality outcome in both women's and children's health. Thank you.
Thanks, Wais. One comment coming in from our audience today, and it's not really a question because I don't see how it can easily be answered, but just pointing to the fact that here you are, we're talking about settings of conflict, and in a setting of conflict, the health system is going to immediately pivot to dealing with the emergencies and crises that conflict throws up. And the ability to deliver routine care that's not related to that emergency conflict setting must be severely compromised. And these are already compromised health systems. How does one deal with that double burden of routine care that you need to provide in addition to the emergency care? Any reflections from your experience in Afghanistan?
Thank you, Richard. I'm working in one of the hospital. Let me give my own experience. Here, this is a complex hospital, and patients are coming from the very remote areas, and care is provided from basic till intensive care. And the routine, if the frontline are not trained adequately, if they do not have adequate experience, if the work environment is not feasible on or better or in a good condition for them, definitely how we could expect quality and how we can expect good care for women and children. So what I want to put is that let's improve the work environment and simultaneously improve the capacity of these frontliners. We need in Afghanistan, unfortunately, we do not have specialized even doctors and nurses. All are trained generic, and we need to develop the capacities in terms of neonatologists, intensivists, and also in the nursing and midwifery area, we need to develop them and specialties like special nurses for the pediatrics, nurses for the intensive care unit, and also nurses for the emergency care. Thank you.
Thanks very much, Wais. Let me turn to Paul now. Paul, in Neha's paper, she has two particular messages which could appear to be in conflict with one another. And I wanted to explore these two messages a little further with you. One of the messages is that priorities of donors are still the primary drivers of influencing the what, where, and how of implementation of women's, children's, and health interventions. But the second message is that we should place greater attention on local actors, local authorities, local service providers, and local NGOs. So my question to you is, how do we promote a better interaction between the donor and the local authority, provider, or NGO? How do we improve that connection?
Interesting. I mean, reading the series and also in particular that paper, that was, shall we say, I mean, not new, but I do realize, of course, that priorities of donors do drive global health priorities. I mean, that's the way funding is basically thematic and so on. But I was not aware. Actually, I'd hoped to see, shall we say, a more, shall we say, mild earmarking as part of the humanitarian, shall we say, funding. So it is an intriguing remark. And first of all, I need to say, I mean, it's never easy to talk on behalf of donors. So, I mean, it's clear donors are very different and perhaps even increasing in unlike-mindedness and so on. And also, I would like to make the point that one thing is donors, I mean, as provider funding. But here, I mean, we are straight into the political realm. with state actors and local actors and basically war parties and some competing for space and power. So I would like to make one point, which I think could have been emphasized in the papers, is that it is really important to avoid doing more harm than good. It's very clear that aid can work both ways, and that conflict sensitivity is perhaps a key recommendation from my side in having the work moving forward. So that being said, it's clear that harmonization, as you raised earlier, I do think having more harmonized guidance on norms, shall we say, the best practice and how that basically can play out in programs that are funded by donors could really be an added value of this process. So I would encourage, to take the work forward, to have a group working. It needs to be inclusive, but also need to be anchored to those institutions that basically have a normative leadership, such as in the health clusters led by WHO, and which is anchored in the UN. When it comes to local actors, this is a huge, shall we say, paradox in aid and humanitarian assistance. We really highlighted in 2016 as part of the World Humanitarian Summit, anchored in the Grand Bargain that Peter referred to. A key part of that, shall we say, commitment, which more than 60 donors, international partners have subscribed to, is increasing the level of funding going to local actors, national local actors, 25%, and it's really proving difficult. No easy answers. But I also would like basically to highlight some of the other parts of the Grand Bargain, which is really important, is, shall we say, better quality of funding, both in terms of having less earmarking, that I think talks to the point of thematic funding, earmarking, and so on, but also points to the need for multi-year funding. So the quality of funding, when quality funding enters working systems for aid, for humanitarian assistance, you have a much, much greater likelihood of having success and results. And my last point, if I may, is basically that, again, I do think the Commission's work and can really play a very important role in terms of helping in standardizing, shall we say, the interventions themselves into, shall we say, a thought-through process of priority setting and contextualization. But also, I do think as we move forward, it is really important to have the agility and the pace of change with the number of actors, with all the forces at play here. It is very important not to have only a technocratic approach to this, but also, to have this anchored in local needs and settings. So yes, I do think the questions coming in and that Esperanza also talked to and ways necessitates the engagement and the true, shall we say, ownership of local actors.
Thanks very much indeed, Paul. Now, we've got 4 minutes to go before we have to move on. And incredibly, for any kind of global health discussion, we've managed to get through over an hour and we haven't talked about COVID-19. But I'm going to ruin the meeting now and get you to say something about COVID-19, conflict, humanitarianism, women and children's health, and the relevance. What impact do you think COVID-19 is having or will have? And this is open to any of you. Paul at the very beginning talked about redefining our notions of security. Well, if COVID-19 has done anything this past year, it's forced us to redefine our notions of security. Who'd like to come in and offer a few words about this aspect before I pick on one of you? Liz, go on, Liz. Well done.
Thank you. As I mentioned, the issue of women, children, adolescent, and the unintended consequences of COVID is very similar to the consequences in conflict in terms of the indirect consequences. And I think what COVID has shown us is that even in countries where the so-called health system is robust, that those unintended consequences occur. So that in countries where the health system is much less robust or is weak or is in a situation of a conflict, then a focus on the women, children, and adolescents is absolutely critical, because otherwise they will, be further and further and further left behind. So that really is the link between COVID and the conflict situation.
That's very good. Paul, did I see you put your hand up?
Yes, I think, the series should then emphasize also public health interventions. It's very clear the closures and, shall we say, the effects of the impact of COVID-19 on societies is huge, and in particular on the informal economies, on schools and so on. One area where the humanitarian sector is far beyond, shall we say, the development assistance sector, to put that way, is in the use of cash-based assistance. So it's clear social safety nets, cash transfers, and so on is key in mitigating the effects of COVID-19. And just my final word here would be, inequalities are just going to increase. So it just points, to women, to girls, and some of the gaps we saw in the analysis are just going to worsen, gender-based violence and so on.
Yep, that's great. And Wace and Esperanza, 30 seconds from each of you.
Yes, and on children. So the lack of access to education caused by COVID is going to be really the next generation of adolescents are going to be severely impacted. But in the middle of this, I want to take a point that Paul raised in relation to how little we have advanced or how challenging it has been to advance since the World Humanitarian Summit on localization. And if anything COVID has shown is that we don't have an alternative but to really help to build local capacity because the responses are local, because communities are the ones facing the brunt of the pandemic, but at the same time responding. And the dependency on international aid has to basically move away from being expatriate driven by being locally sourced. So I think if we manage to get that right, this imbalance between emergency and routine care potentially can be a little bit addressed.
Very good. Thanks, Esperanza. And Wace, do you just want to have a very, very brief remark on this?
Thank you. In addition to what other colleagues shared, I would also add that since COVID has affected all populations, specifically women and children, and initially even countries were not prepared for such pandemic and disaster. So I would also add that why we should not take initiative on the e-health and also including e-learning in order to continue the services. Thank you.
Thank you. Yes, thank you. We have had a digital acceleration like no other. Well, look, thank you to Liz, to Esperanza, to Wace, and to Paul for your excellent reflections today. And we're now going to go into a short video segment.
As you know, Somalia has been affected by chronic insecurity over the last 3 decades. We've conducted a mixed method study to assess factors affecting humanitarian health and nutrition response for women and children in Somalia since 2000. Our method consisted of reviewing available quantitative studies in Somalia, but also conducting 32 interviews of representatives from UN agencies, international and local NGOs, and federal and local government officials. Our results have shown that the available quantitative data is very scanty and conclusions cannot be drawn upon them. Our qualitative study has confirmed that contextual issues, most notably clan dynamics and women disempowerment, affect these humanitarian services. And operational difficulties include lack or inflexible funding and inaccessibility to most vulnerable populations. We know that a chronic shortage of commodities and human resources might also affect these interventions. our recommendations included a government and public partnership that can allow the reach of remote areas, use of technology, and also operational research is needed to ascertain the use of female health workers to provide primary health care in rural and remote areas of Somalia.
From the Syria study, we found that the volatile security context in Syria led to massive population displacement and interrupted continuity of care. There was also an exodus of healthcare workers following recurrent attacks on facilities and restrictions on population movement and therefore access to healthcare. And these factors combined were found to influence healthcare seeking behaviors. And we have an example from delivery care, where we found Syrian women to prefer home births or request C-sections to mitigate the risks associated with the insecure environment, leading to increasing rates of facility-level C-sections. So as shown in this graph, across geographic regions, C-section rates were particularly high throughout the conflict. And here we have data from 2014 to 2018 across various different districts. The partial breakdown of the healthcare system and the delay in humanitarian coordination also led, at times and in certain geographic locations, to gaps in intervention delivery and coverage along the continuum of care for women, children, and adolescents. And this raises a concern regarding the lack of emergency preparedness in a region that has been particularly prone to conflict, and also led to fluctuations in family planning services, newborn care, infant and young child feeding, and immunization coverage.
Well, thanks for staying with us. We're almost at a conclusion, but now it's again my privilege to introduce really an absolutely unparalleled global leader, the Right Honourable Helen Clark. If ever there was a model of a person about how to play a powerful and compelling role after being a head of a country, as Prime Minister Helen Clark was in New Zealand, then she is that person. Her leadership in global health has been truly astonishing. Contribution she's made to thinking through how the world should respond after Ebola, now co-chairing the independent panel set up by Dr. Tedros to look at the COVID response. Its interim report just published a week or so ago with very powerful and far-reaching conclusions. And as I mentioned at the beginning today, her role co-chairing our Lancet Commission on the Future of Children. So it's a great pleasure to introduce Helen Clark for some almost final, but not quite final, almost final reflections.
The Lancet series shows how women, children, and adolescents suffer persistent and disproportionate hardship and inequity in many regions of the world, but particularly in conflict settings. This suffering must not continue, but to stop it, far greater funding, political commitment, and leadership are needed. In particular, 3 areas are crying out for greater attention. They are gender-based violence, adolescent health and well-being, and early childhood development. Looking at the first of those, the Lancet series estimates that 21% of displaced women experience sexual violence. Those women need targeted reproductive, mental health, and social care, but it's often unavailable, with women and girls being denied even basic contraception, abortion, and post-abortion care with devastating consequences. In fact, dealing with gender-based violence accounts for just 0.12% of all humanitarian funding. And 2/3 of prevention and response programs don't receive any funding at all. This is reprehensible. The second area crying out for attention is adolescent health and well-being, and it's linked to the first, because adolescent girls are at unique risk of sexual and gender-based violence, with up to 1/3 of those in humanitarian settings reporting that their first sexual encounter was forced, but their health and well-being is so often ignored. By far the best and the most cost-effective way of addressing these needs is through integrated interventions, which would address GBV and adolescent health and well-being alongside reproductive, maternal, and newborn services. Every $1 invested in contraception yields $30 to $50 in benefits from reduced infant and maternal mortality, and $60 to $100 in long-term economic growth. Meanwhile, just $5.2 per capita each year on adolescent health would provide benefits worth 10 times that. It would save 12.5 million lives, and it would prevent 30 million unwanted pregnancies. Who wouldn't want those results? Finally, we do need much more focus on the effects of conflict on early childhood development, including with respect to low birth weight, chronic illness, mental health problems, and violence. What happens during early childhood can improve health, growth, and development outcomes, boost productivity in later life, and improve social cohesion. Yet, an analysis of humanitarian response plans in 2018 showed that only 58% mention nutrition interventions for young children. Under 25% of those plans mentioned safety and security, and even fewer mentioned responsive caregiving or early learning. So, to address all these issues, we have to empower the local actors who are best able to tailor responses to their local context. And it's important to much more effectively contextualize guidance for conflict settings. The Lancet series recommends establishing an independent technical advisory group, which would establish a framework for intervention and accountability. The Partnership for Maternal, Newborn and Child Health supports that. We think it should be multi-sectoral with close links to relevant cluster structures like global health, protection, nutrition, WASH, and education. And it should also be guided by local stakeholders in line with the movement to decolonize global health, enabling better responses and contributing to building peaceful and stable communities. Over the next 2 years, PMNCH will be working on a global roadmap to support the integration of sexual, reproductive, maternal, newborn, child, and adolescent services in humanitarian and fragile settings. Meanwhile, our new strategy for 2021 to 2025 will see our global partnership working to drive down preventable morbidity and mortality, and working to advocate holistically for essential maternal, newborn, and child services, sexual and reproductive health and rights, and the health and well-being of adolescents. If a better, more sustainable future for all is to be built, the needs of women, children, and adolescents have to be placed at the center of all humanitarian development and peace-building efforts. This can't be the responsibility of just any one sector. All must demand greater alignment, investment, and political attention for those who, through no fault of their own, are trapped in situations of conflict. Only then can the unequal burden of preventable morbidity and mortality be addressed, and only then can we truly ensure that we are leaving nobody behind.
The large and increasing impact of conflict globally may have resulted in the deaths of 10 million children in the last 2 decades, and 600 million women and children currently adversely affected. Women and children are rarely combatants in the conflicts, and the adverse effects are largely due to the indirect effects of the conflict on food security and malnutrition, increased rates of infectious diseases, and disruptions of the health system, reducing the availability and quality of care, even 50 kilometers or more from the site of active conflict. The needs for health and nutrition services for women and children in areas affected by conflict are largely those needed anywhere. But decisions must be made on what can be delivered and how to do it, which varies by the nature of the conflict and pre-existing factors, including the strength of the public and private health systems. This prioritization would be facilitated by global guidance that is specific to conflict settings and by a decision-making framework that incorporates the local context as proposed in this series of papers.
Through our case studies and global analysis, we identified positive features about reproductive, maternal, newborn, child, and adolescent health and nutrition in humanitarian settings, and also important gaps. The provision of maternal health care is a priority in all contexts, but there are critical needs that have not been met yet. A sad consequence is the unacceptably high maternal mortality that has been documented in conflict-affected settings. Adolescent sexual and reproductive health is recognized as an important area of focus, but very little is done regarding data collection and interventions, despite the disturbing increase in child marriage among refugees and prevalent sexual violence, which harm large numbers of young girls and women alike. The absence of a gender lens is probably the most glaring gap in humanitarian programs, policies, and interventions that make no reference to the urgent need to reduce gender disparities in order to advance the health and well-being of girls, adolescents, and women. As members of the branch consortium, we will continue generating the evidence that is needed for effective action in these and other areas, working together with a network of partners to better serve adolescent girls and women and advance gender equality in some of the most challenging circumstances imaginable.
Hello, everyone. I'd like to start with thanking the Lancet for publishing the series on armed conflict. Good science and accountability based on evidence are critical. The COVID-19 pandemic teaches us much about the politics and science of numbers, something the Lancet has not avoided, especially Richard Horton in his thought-provoking offline columns. The rapid spread of fake numbers and interpretations is not new in public health, but armed conflicts are one of the most significant battlegrounds between inflated, wrong, and made-up numbers and science that aims to approximate the truth. There's much debate about the direct death toll due to violence, and even more debate about the indirect adverse health and nutrition consequences of armed conflict, affecting incredibly large numbers of women and children. We need to do better on generating evidence on mortality and health consequences of conflict, to improve health action and accountability, and to counter false numbers driven by political interests. The branch initiative is a small but important step. The countdown to 2030 for women, children, and adolescents' health, which I represent here, is fully committed to continuing to work with branch and others to improve the evidence on conflicts. To end with a quote attributed by some to George Orwell, "During times of universal deceit, telling the truth becomes a revolutionary act." Thank you.
Branch was hampered, in some instances seriously hampered, by the lack of relevant data. The humanitarian enterprise remains, as I have called it before, a relatively data-free zone. It relies heavily on shared organizational experiences and on personal observations. These both have considerable value in themselves, but the role that carefully collected and analyzed quantitative and qualitative data can play has not yet become adequately prominent in the policymaking arena. On the other hand, Branch, as a primarily academic consortium, may not express to a great enough extent the appreciation it has for the non-governmental organizations whose work it has tried to capture in this series, and especially not for the local NGOs that are always on the front lines. The relationship between those who analyze and those who provide services is not either or. My point is that the proper balance between learning and doing has not yet been achieved. Thirdly, even more out of balance is the role of communities in setting their own priorities and determining for themselves the nature of the assistance that they receive. We have learned a lot recently about the need for community engagement, but in my opinion, we have not learned how to effectively and seriously engage. The role of those affected by conflict should not just be to follow our instructions. It should be to play an honest and respected role in the decision-making processes themselves. These three elements, academia, the healthcare providers and civil society, including the United Nations agencies, and the local communities who are the recipients of aid, need to work in a closely symbiotic fashion if the horrible effects of armed conflict are to be mitigated. Branch is a good start towards, first of all, recognizing that this kind of balance needs to be achieved, and secondly, towards actually making it happen in a way that works most effectively and efficiently to allow affected populations to get the most help, to have the least suffering, and to restore their ability to lead productive and dignified lives.
Well, thank you very much, ladies and gentlemen. This brings us to the final slot in our launch proceedings, and it gives me great privilege and pleasure to talk about what happens now. So the one thing that will not happen is, as far as we can help it, is that this series and its all sister papers just sit on shelves and gather dust. That was never our intention. So I would like to start by encouraging you to visit the website of the Branch Consortium. It's World Wide Web, branchconsortium.com, and it has all the information in the materials, and also importantly, an invitation for the consortium to expand. So we started off with a core steering committee, and then we expanded to a lot of our most important partners in countries in some of these regions, and we recognize that that consortium has got to grow. So this is an open invitation for people who are interested in the space, who like to throw some scholarly light on the issue of women, children, adolescent health and nutrition in these settings, sexual reproductive health. How can we do better? And we can do better together. So this is an invitation for the expansion of the consortium, which I hope will gather momentum. Also on the website are the knowledge products and information related to the series and the publications that we have had. But I'd like to especially point out that in partnership with the PMNCH, the Partnership for Maternal Newborn Child Health at WHO, and we are very grateful for their support. In moving forward, we would be organizing over the next few months a series of regional workshops. We are taking advantage of the post-COVID reality of working virtually, of now taking some of these findings, the key recommendations, and also things that we may not have considered for a more in-depth discussion with implementing partners, key NGOs in the geographies, governments, and other academic groups in the very regions and geographies where conflict is a way of life. So that will happen in the EMRO region, in Afro, in Southeast Asian regions, in the region of AFPAC, where for the last 40 years, as my colleague Wise said, there has been nothing but conflict. So that is an extremely important initiative, and we would like to welcome you to participate in those. And the PMNCH will be helping us identify how we can do better and produce things like policy briefs, advocacy materials, and some toolkits that will allow better planning as we move forward. We also are very keen to ensure that in this process, the global normative agencies and the UN system, whose responsibility it is to spearhead a lot of this work, is very much front and center. And we are looking forward to working closely with the UN agencies like UNICEF, UNFPA, UNHCR, and also the World Health Organization, who has a normative role on this. And I'd like to take the opportunity to particularly remember and recognize the contribution of Pete Salama, whose death anniversary just fell this last weekend. Pete was a personal friend, and a very close colleague who helped us shepherd and guide the genesis of this branch consortium, actually from his time at UNICEF. And when he moved on to the World Health Organization, he was nothing but supportive, and he helped open many doors. And I'd like to remember him today as a model colleague who devoted his life to serve children and women and families in some of the most difficult geographies of the world. So Pete, your memory lives on, and your work and help to the branch consortium will always be remembered. And I'd like to pass the floor on to my dear colleague, Claude Blanchet, to give a final vote of thanks and some of his closing remarks in this process. Thank you.
Thank you very much, Sophie. So before we close this event, I would like to take a few minutes to acknowledge and thank the many contributors that have supported the branch consortium to complete such a large program of work. So on behalf of the branch consortium steering committee, I would like to thank the Lancet team, and more specifically Jocelyn Clark, for encouraging and facilitating the publication of this series, along with other journal partners, BMJ and BMC Conflict and Health, for publishing much of the underlying technical work. I would like to thank PNMCH for supporting this launch event, as well as the dissemination process that will take place in the near future and that Sophie just described. And the generous funders that have supported a wide range of activities of the consortium. The International Development Research Center in Canada, and more specifically Kamal Mahmoud, Montasser Kamal, NORAD, the Bill and Melinda Gates Foundation, and more specifically Jana Patterson and Claire Merchant, UNICEF, and the Family Larson Rosenquist Foundation. We also want to thank all the academic institutions of the branch steering committee members for their support and in-kind contribution that helped enable committee members to lead the consortium's work. I would like to thank all our research partners in Afghanistan, Pakistan, Lebanon, Yemen, Somalia, South Sudan, DRC, Mali, Nigeria, and Colombia. In total, 82 researchers and 14 different countries contributed to these studies. I also would like to thank the UN agencies, the international and national organizations who partnered with us to produce several of the papers in this series. Finally, as a consortium, we strive to continue improving the humanitarian health response for women, adolescents, and children in conflict settings. We are committed to continue our efforts in building the evidence base and working with national research institutes in crises-affected countries. On that note, I now close this meeting with our best wishes to all of you for the year 2021. Thank you.